Θα έχουμε μία διάλεξη ακόμα από τον Dr Magno, ο οποίος έρχεται από το Πανεπιστήμιο της Κατόλικα της Ρώμης, από την μονάδα μαστού του καθηγητή Φραντσεσκίνη Τζαμπάολ. Πρέγκο. Και μετά θα έχουμε καφέ. Ταυτόχρονα μπορείτε να πείτε καφέ. Go ahead.
Good morning, everybody, and thank you for this wonderful opportunity to share experiences and ideas about a model of breast cancer, and above all, about how to achieve the best results in terms also of quality of life, which is an issue that, as you know, is often overlooked. We know that as oncologists we have two major goals in our care. First of all, we should provide the best survival for our patients while preserving the best quality of life. Unfortunately, these two goals are not easy to combine because our treatments are always invalidating, debilitating, mutilating, and deeply impact the quality of life of our patients. So, as the real experience of a woman with cancer is that at the end of the treatments, we see just the surface of what she feels deep inside, because under the line of water there are so many needs that are not always assessed and addressed. And it has been calculated that at least 2/3 of patients and survivors must face some clinical, psychological, physical needs that are not properly met by our conventional medicine. Among the most unmet clinical needs, there are, for example, lifestyles. Body weight. We know that body gain is a major issue in our patients, and body weight and obesity is related to at least 13 types of cancer, including breast cancer, but it affects all the cancer journey from diagnosis throughout the survivorship. And there are many guidelines, as you know, that state that we should screen every cancer patient with a nutritionist, but unfortunately, this is not the case in the clinical practice. And another issue is exercise. Physical activity improves in all the meta-analysis the results, the prognosis of our patients, and we should recommend aerobic and resistance exercise in all patients, as stated by the ASCO guidelines, but that is not the case, again, in the clinical practice. And even in our center, for example, in this population of more than 500 cancer patients awaiting for surgery, less than 20% were physically active, and of course they had some problems with the body composition. More than 55% were with an average fatty mass beyond the range of the normal ranges. So, what have we done in our institution in order to improve our clinical care and the quality of life in our patients? Our institution, Istituto Policlinico Universitario Gemelli, is the largest hospital in southern central part of Italy, and we have huge numbers in terms of cancer patients in the Comprehensive Cancer Center, and particularly in the breast unit, we perform more than 1,300 breast cancer surgeries for malignancies, and we have this team which is directed by Professor Franceschini, and we have developed in the last 20 years a program of integrative oncology, which tries to combine the two goals, the survival and the quality of life. First of all, introducing in the early 2000s a psychologist, and then acupuncture, reflexology, then nutrition, and more recently in 2019 we launched a new Center for Integrative Oncology. And we requalified the two terraces in our hospital. They were changed radically into a healing garden, which is a place where, of course, they are built and conceived not only on functional criteria, but also on aesthetical and welcoming criteria. So these are our clinical spaces for integrative oncology. And we propose a new model of care which combines in the same place, in the same time of care, the best available treatments in order to cure cancer, to prolong life, but also all the subjects and the issues that can improve quality of life in terms of lifestyles, well-being, and complementary treatments based or evidence-based, of course, to manage side effects and toxicities. So the definition of integrative therapies in oncology is treatments that are provided alongside and not instead of conventional therapies, that through psychological support, lifestyles, and complementary approaches may improve well-being, reduce side effects, and hopefully risks of recurrence. So our integrative diagnostic therapeutic pathway must follow these three criteria. First one, it has to be systematic, not just for some patients who requires, but for every patient. Must be coordinated by clinicians and must be synchronous. Must take place in the same place, in the same times of conventional care. The steps are four: prehabilitation, supportive care, rehabilitation, and proactive follow-up. Talking about prehabilitation, we perform a screening of nutritional and lifestyle needs and psychological needs at the very beginning of the cancer journey. In every patient receiving a diagnosis of breast cancer, first prior to surgery or prior to neoadjuvant chemotherapy, she is evaluated by a nutritionist and a psychologist, and we perform a real triage in order to evaluate if they have some scores that are at high risk of low compliance to our treatments. So we can propose a prehabilitation program right in the beginning of our journey, before surgery, for example, in the physical activity classes inside the gym of the hospital. But here we have another problem, the academic training of kinesiologists, because you know that specialists in physical activity are not inside the hospitals and they are not trained in oncology. So we just won an Erasmus project for this issue, and last week we had the first kickoff meeting in Romania, which is launching this team of advancing the field of exercise oncology. Another step is supportive therapies, how to manage side effects during the chemo or radiation therapy or hormonal treatments, even through non-pharmacological approaches. And we have guidelines which allow us to use these treatments, the ASCO guidelines for breast cancer, for example, but also the ASCO guidelines for chronic pain, where, for example, it is recommended acupuncture for the joint pain during hormonal treatment, anxiety and depression. Mindfulness, for example, is very much indicated in this kind of settings, or fatigue, which is a huge problem, as you know, and where exercise, for example, has huge evidence of safety and efficacy. During the active treatments, we therefore propose acupuncture, exercise, nutrition, and psychological support. And particularly for acupuncture, we use it for pain, fatigue, nausea, and hot flashes. What about rehabilitation? We intend, of course, both physical and psychological rehabilitation. For the physical rehabilitation, we use a combination of manual and mechanical assisted procedures in order to prevent lymphedema, but also fibrosis and functional limitations of the upper arm. We propose mindfulness classes inside the hospital. This is the gym of the hospital and the healing garden at the 10th floor. Qigong sessions, which is a sort of a Tai Chi, you know, and also classes of art therapy and music therapy, which are not meant to amuse patients, but to try to help them to manage and re-elaborate the traumatic experience of disease. And last but not least, follow-up must not be only a clinical surveillance of possible relapses, but we should work in order to reduce the risk, for example, through the physical activity, exercise. So rowing on the Tevere River with classes of patients, or other activities in nature-based settings. Mindtrek is a combination of exercise and mindfulness, so meditation programs. And Metadynamic is a wonderful project meant for metastatic patients, who will live a 1 week immersive journey with healthcare professionals, experts in integrative therapies, all together. And I would like, in my final part of the speech, to show you a short trailer of this experience, because I find it very, very moving and significant. So this is the paradigm, the model that we propose as a way to enhance our chance to improve in the same time the quantity and the quality of life of our patients. So thank you for your attention. Now, just this short trailer, if you can.
Thank you for your excellent presentation.
Dire che ho i giorni contati non significa nulla. È stato sempre così, per noi tutti. Ma l'incertezza del luogo, del tempo e del modo che ci impedisce di distinguere chiaramente quel fine verso il quale procediamo senza tregua, diminuisce per me col progredire della mia malattia mortale. Chiunque può morire da un momento all'altro, ma chi è malato sa che tra 10 anni non ci sarà più. Il mio margine di incertezza non si estende più su anni, ma su mesi. Da Le memorie di Adriano di Margherita Yourcenar.
La vita è meravigliosa, nonostante tutto. E io credo fermamente in questo. E nemmeno una fottuta malattia mi toglierà questo pensiero.
May I just add one thing that comes from my heart?
Yes.
I'm deeply moved to be with you today for a number of reasons. The first reason is that half of the words that I used and this concept that I use comes from your culture and your ancient Greek. So the second one is that I come from a region in Italy, Salento, which is right in front of Corfu Island, where are places and villages where is spoken an ancient Greek dialect. And the third one is that I used to study in my high school ancient Greek, and that has shaped my way of think, of talk, and also probably the way I try to be a better physician. So I think that if we want to rehumanize medicine, we must start from here. We must start from the roots and tradition. Tradition is not celebrating the ashes, it's about preserving the fire. So thank you for your invitation.